Mark your calendar, AAOS 2026 registration kicks off November 3rd. From March 2nd to March 6th, New Orleans is where orthopedics comes alive. Reunite with classmates, share ideas with peers, and connect with colleagues worldwide. This is where your best moments turn into memories. Don't miss out on early bird savings. Register now at aaos.org/NOLA2026. The AAOS Bone Beat Orthopedic Podcast channel is pleased to welcome you to the latest episode of the AAOS Now podcast. This exciting new podcast series covers a broad range of topics related to orthopedic surgery, practice, and advocacy.
Hello, I'm Robert Orfaly, Editor-in-Chief of AAOS Now, and with me is Dr. Amy Ladd, who is the Chief at the Chase Hand Center and a Professor and Vice Chair in the Department of Orthopedic Surgery at Stanford University. Amy, thank you so much for joining us today, and we're going to talk about innovation. And you have been a leader in innovation in orthopedic surgery for a long time. Many published articles and patents and trademarks. So start with, what innovation means to you, what the different forms of innovation have been for you in your career, and what has had the most meaning or most impact in your career.
Thanks, Rob. Thanks for the opportunity. Innovation is, maybe it's overused word because I think we're all innovators. To me, it means creativity and something new that might change how we do and approach things. And, our guest speaker yesterday here at the Academy was Captain Captain Sullenberger.
Right.
And he opened with, he always has had intellectual curiosity. And I think that's true of all of us as surgeons. We want to make the world better and make people healthier in whatever form that takes. So innovation to me is taking what's around you and trying to make it better in creative ways that could be devices, gadgets, or just a different way of thinking.
Right. And I know that you've done a comprehensive body of work on one topic in particular, which is thumb CMC arthritis. When you talk to a resident or trainee, do you think it's important to really focus on one area and really develop that deep multi-year expertise in one area? Or do you think there's also the kind of idea, the Edison who's just the tinkerer and kind of creates all kinds of different thoughts and creativity across the board?
Well, that's a great question. So first of all, my interest in base of thumb arthritis evolved over, so I've been in practice 35 years. It was a very divergent, circuitous path to a focus. And so that's a roundabout way of saying, no, go after lots of things initially and see what kind of sticks. And at least for me, I'm definitely a dabbler. My interest in CMC arthritis took about 15 years. There were steps along the way. I grew up in a Kodak family. My dad worked for Kodak, who sold x-rays. He desperately wanted me to be a radiologist, but I couldn't stand that black box. But ironically, most of my research is around imaging and movement. And so there was a focus on imaging. I worked with a dentist who was doing a 3D multimodal atlas of teeth and wanted a similar concept for the human body, and the CMC joint was the perfect avenue. And so it was kind of funny because my training had a lot of CMC arthritis, but I only took interest into it out of curiosity for a question about how can you better understand it. So my current lab focus is predict, prevent, and treat arthritis of the base of the thumb. So I think that approach could work throughout the musculoskeletal system.
Right.
So you asked me about what do I tell trainees. I don't try to impose, do CMC arthritis because that's the coolest thing. Even though it is for me, it's certainly not for them. But more the curiosity of how things move, how they break down, how we can intervene. So it's different as a trainee because you want them to think broadly, and they're choosing their specialty at that point. Right? But if they're a fellow or there's someone early in practice who wishes to pursue something that is research focused, then they have to kind of pull it in and say, okay, I'm going to ask a question and I want to stay with it for a period of time and work through it.
Right.
So those are two different things. First is curiosity, go for it. And second is, if you really want to do this for a career, be curious and then work on something for a while fairly linearly and see what other opportunities open up.
Absolutely. And your work on prevention of arthritis is certainly not unique in orthopedics, but maybe less common because we tend to see patients after the pathology has already set in.
Right.
And so we're more on the treatment, even if it's not procedural treatment, but the treatment of it. Tell me a little more how you got interested in kind of taking a step back before, orthopedics traditionally enters the picture.
Yeah. So much of what we do is end stage. And wouldn't it be cool if we could be partners with immunologists, say, to predict and genetic markers, geneticists, think on that bigger scope. So little, again, dabbling projects, looking at genomics of arthritis, big joints versus little joints. Is there some clue in there? Are they different?
Yeah.
Our preliminary research says big joints break down differently than little joints. So I don't know where that next step is. Maybe someday you'll have a blood test and say, okay, well, you are predisposed to get arthritis of the knee, but your hands look pretty good so far. So let's focus on your knee. I don't know where that goes, but right now I'm very interested in patient-specific prevention of arthritis in our NIH cohort, which I've worked with Brown University over the past 15 years. We examined early arthritis and how it progresses, and that seems to be systematic and consistent for that early disease.
Right.
So what if we can design surgeries that preserve the trapezial metacarpal joint? I think we as hand surgeons were often pretty glib about taking out the trapezium, but what if we could preserve it?
Absolutely. So that's something that has already had an impact on your clinical practice, I would imagine.
Yeah, and trying to work on patient-specific osteotomies that kind of dial in it for early arthritis. Can you reverse the clot? I mean, we think bigger joints, you've got more to work with and less deterioration of a joint relative to typically a trapezial metacarpal joint when it's completely devastated by the time you operate on. But what if we can do that sooner? So that's one thing. And then implant development for something to preserve the trapezium, which has not been figured out yet. And I think our consortium with Brown and Stanford has a good handle on how it normally moves and functions. And therefore, potentially that's the basis for emulation of a joint replacement or hemi replacement that emulates normal movement and doesn't, kind of relegate it to a mini total hip.
Right. So kind of challenging traditional thinking about, just put a sphere into the joint or, a tendon weave and that's good enough. But rethinking how it moves and how we can recreate that.
Right. What if we can offer more? I mean, I often talk about we offer good enough, which is pain relief. It's pretty good if you're miserable, but what if you restore it? And the analogy I usually give is the girdle stone. Girdle stone was pretty good for tuberculosis or osteoarthritis of the hip years ago because you took out the painful joint.
Right.
But a resection arthroplasty, you're not going to walk again normally. You're not going to have the function of your leg normally. So that's the caveat. Well, the pain's gone. Mm-hmm. Is that good enough? I think we can do better.
I'm sure we can. Well, I mean, some surgeons are fortunate to have direct experience with skilled innovators during their training. Let's say someone comes to you and they're mid-career, but they just feel the inspiration to, challenge current thought, or they feel like they have the big idea of their career. How would you counsel them to develop that interest without that direct mentoring?
I think all's on the table. You know, the big idea obviously is going to take a lot of energy. The quick and easy, you know, like I can do that better, or what we need in the OR is X. We need a little device. I'll give you an example. You know, for scaphoid non-unions, a decade ago, kind of the rage was vascularized bone graft. You know? And like, you tamp it in, but you worry about that little vessel. And I said, well, let's just create this C-shaped tamp that allows an opening so you can put the vessel in, and when you pound it, it's, you know, the pressure is away from the vascular thing.
Sure.
So I worked with a student. We went to the machine shop. We developed one, and that was simple. And it's a simple solution. You're gonna make no money off it. No one wants to, you know, push a curette or a tamp or anything like that. That's just a surgical instrument. But that's easy. I mean, anybody can do that. And so it took nothing other than a little time and energy and partnering with someone who's curious.
Absolutely.
But other things, if you have an idea that, and I'll give you an example, still have a patent on it that's never developed, but I want to. We started a company around it and haven't really materialized it. Kind of a spring, a deploying spring in a distal radius fracture. I kind of worked out the idea that would work, that counteract the mechanical forces. And that was just something I really thought about, I read about. I went to Michael's and the hardware store and played with all sorts of things. I looked at levers like car jacks, clips. I have one somewhere, a hair clip, and the way they spring load, you know. And so the process, if you have an idea like that, you know, you hear the back of the napkin thing.
Right.
You write it on anything. It could be napkin, a paper towel, but usually paper and ink works better. And you sign it, you date it, and you need it notarized, and you need a witness. And that's super simple. I mean, a lot of people in their office, like my assistant is a notary, and that starts the intellectual property.
Wow. Okay.
And that particular thing was 2006 or something like that. And I mean, I used black and red ink on a with Sharpies, you know, and that's the picture. I don't even know where the original is, but it was done. And even if you put it in a drawer for 5 years, that really starts the process. Then you think about it, and the best thing to do is do a patent search. And now it's super easy. It used to be you had to kind of, it was arcane and you had to sign up and whatever. But Google has a patent search. There's an open, I can't remember the name of the website, but it's super easy to find out. And you put in keywords and see if there's anything like it. And if you're really serious about it and your search doesn't find anything, then I would suggest talking to a patent attorney. And it helps if you went to school with somebody who knows somebody. I mean, that's a lot of how we work, and you know, just get kind of a rough idea.
Right.
And then run a patent search. It's a little bit like writing a paper, right? You know, it's just like, oh, I've got this great idea, and you check the literature and someone's done it. You know, you don't want to invest all that time and energy. But
Absolutely.
But again, back to networking. I mean, all of us know other creative people with other skill sets, you know, like business school. If you have access to students or residents who have like an engineering background, the kind of the curiosity team. And I strongly advise building a network. And sometimes it's your good friends, it's maybe family members, whatever. But for small projects, I think that's a really good way to start. And at some point along the way, you do need some legal counsel. So again, you can do it on the fly. But when you're serious, that's another chapter. And I'll stop there if you want to ask.
Right. Well, I mean, you know, getting perspectives from people of different backgrounds, you're saying too, is really useful because they see the problem from a completely different lens.
Yeah, exactly. And, you know, I've got some little thing that I'm working on, a trigger pad, you know, for trigger fingers, because I've had one and I've been inspired about what works, you know. And I ran it by an engineer, and he helped me look for the patent. And the patent that's out there is pretty close. I'm like, okay, I really want this. They've never done anything with it. My next stage is modifying it just enough. And, you know, it's kind of, what does it take and what am I interested in? So then if you have some sort of little gadget, if it's pretty simple, then you talk to, say, a company that works with stainless steel or metals or whatever, if you want to form it. Or if it's a soft goods, people who do manufacturing. And again, it's find your network. There are resources, if you're at an academic institution, like the engineering schools or bioengineering or whatever, a lot of available resources. If you're in private practice, got to be a little bit more creative beyond your own network, but they're out there.
Right. Right.
And if you have something big, it's the idea of your lifetime, probably the way to go is either institutional, which has its caveats, or industry, which also has its caveats. So institutional, if you're associated with one, again, a lot of bright students.
Right.
The caveat is that most institutions want a piece of the pie. And the minute you involve a graduate student or a trainee, then that liaison is formal and the university or institution is involved. So if that's the case and you think you need that kind of networking, then you need to go to the people who oversee intellectual property and technical license transfer. And it's a really good idea to do it early on because you want to know where the landmines are. And very few approach it, oh, that's, we need a piece of this. This is the greatest idea, whatever. Quite the opposite. They'll help you with patent searches. They'll help identify sometimes companies that might be interested.
Right.
But the catch is they're involved. And so should you be successful, the most typical pattern is 1/3, 1/3, 1/3. So if you had something that was licensable, which is different than intellectual property.
Right.
Licensable means it will make money.
Right.
The institution gets 1/3, the inventor or inventors get 1/3, and if you're in a department, they typically get 1/3.
Right.
So
Right. I was going to kind of move to a different innovation that you've also worked on, which is trying to improve the power of people's golf swing. So I know you're a golfer. You've been involved in that sport for a while, but tell me how you got interested in that from a research or development standpoint.
Well, it's a perfect example of an institutional involvement. So yes, I'm married to a retired golf pro, and I actually quit for 30 years, which was a good thing. But a colleague of mine at Stanford, so Jessica Rose, and I taught a course called Anatomy of Movement, which is a multidisciplinary course. And it was project-based. So we had undergraduates and graduate students in engineering and medical students. And each project, brought people together with disparate backgrounds. And one which was related to the golf swing was, got a bottle of water here, reach and grasp. Children with cerebral palsy. So
Right.
trying to identify what are the metrics of grabbing a bottle or a glass and bringing it to your mouth and drinking it. And the predicate is walking. So a motion lab with little ball markers or typical setup for a motion lab. And walking is orthogonal and, it's in one plane and it's repetitive cyclic. Nothing in the upper extremity is cyclic and in one plane.
Right.
Except something as simple as reach and grasp. So we were replicating something like the gait cycle in children with cerebral palsy. And interestingly, we found that of all the markers, wrist, fingers, hand, trunk, whatever, the most typical of severity was how flexed their elbow was. And if their elbow was flexed, then they had to move their whole body to get the glass to bring it to their mouth. And so it was something that was kind of, exciting and expositional, as it were. So the golf swing was taking something that was slightly phasic and not quite uniplanar, but repeatable.
Right.
So we did the same ball markers like you do for walking on elite golfers. And these were either Stanford golfers or professional golfers, so elite, and we started with male golfers, put the markers on, and we found that their motion was reproducible, efficient, and powerful, which is sort of like, duh.
Right.
But to quantify it was pretty exciting, and they had a very tight curve, whether someone was kind of stocky or tall, or they had little nuances to their swing, just like people's walking personality. But the efficiency was reproducible consistently. And then and this again started as a student project, but it is a much bigger project. And then we put low and high handicappers doing the same thing.
Mm-hmm.
And handicap is just a number, and it reflects a lot of things. But it turns out it is reflected in the swing as well.
Right.
So, that it was inefficient. And I hate to say it's like cerebral palsy or spasticity, but there were mechanics that were inefficient, and potentially as a training tool to become more like the elite golfers, of which a very, very consistent pattern. So because we did it at Stanford, we involved the Office of Technical Licensing, and we have 2 patents. And still trying to work on that. What we're trying to do is actualize it to the field with something called IMUs, which are inertial measurement sensors. They're kind of all the rage now with measuring motion and activity, and et cetera. But trying to put wearable sensors so people can practice and get feedback out on the field, which is the range or the golf course.
Excellent. I mean, I'd ask you to analyze my swing, but I think I might break the machine with my inefficiency.
It's one thing to analyze and intellectualize. It's another thing to do. So the golf swing, as you know, you probably heard, the longest distance in golf is the 6 inches between your ears.
That is probably accurate for me, for sure. Well, kind of moving back to the field of orthopedics, obviously orthopedic surgery has always historically had a very intimate relationship with industry, with the people who actually take your cocktail napkin drawings and help you, turn it into a commercial product when tools or implants are required. And I know that you have worked with industry, you've even provided leadership to industry interests as part of your work in this area. Tell me what your view is of the relationship that would be the ideal state between orthopedic surgeons, innovators, and the industry partners that we rely on.
I'm glad you brought that up, because we talked about it briefly earlier, and there are caveats and there's enormous benefits of working with industry. I mean, it's a current state where research funding is diminishing, if not cut off, and harder to do at institutions. And look at COVID and vaccines. That was a hybrid model of success of private, institutional, and industry. So. I think that's the reality, and I think that's actually where you get the best results, where you get people with bigger budgets who can help you think about problems. So industry as a whole is an absolute essential partner to innovation for big stuff. And, institutions may do the little stuff. I mean, there's lots of stories. And look at the computer industry, typically institutionally started and then just goes elsewhere and mushrooms. But so if you have a device idea, the caveats are, you give up a lot, but you gain so much more. If it's something that needs a clinical trial, if it's something, even a feasibility study, you just can't do it without industry and money. I mean, you can raise money to a point, but to do the kind of ecosystem of device to patient use to be FDA approved is a long haul.
Absolutely.
So most big players have, teams that are part of the R&D. So that's typically where you start approaching them. And, it's a pitch. You're probably going to pitch to multiple companies. It's, at one point I wanted to get a business degree. You kind of learn on the fly, but then God, there's so many resources online that you can look at how to put a business plan together, how to do a pitch. So typically you'd meet with engineers and R&D people and marketing people. There'll be a surrender, right? Your original idea, like, well, no, we think this is better and we can't do this and X, Y, and Z. So there's, maybe it's finding the right symbiotic relationship as opposed to feel like your baby's been taken away, so you will give up, but you will gain so much more. And the relationships with industry, even, if you pitch to different ones and it's not a right fit, they're great contacts for the future.
Absolutely. And one thing that struck me in my interactions is that you could call it marketing, but they sort of, how you would use this tool or how you would ideally perform, but often they have the better sense of like, how would the world of orthopedic surgeons, view what you're doing, and their input is sort of useful in that regards of knowing how to apply your concept to a broader audience.
Yes, although you should be thinking about that as well. How can that little CMC joint relate to the foot or the ankle or the shoulder in a bigger scope? You are absolutely right. And I think right now, and hopefully more than hand surgeons listen to this, but a lot of the traditional kind of trauma or implant companies trying to find where foot and ankle and hand fit in. It's not really trauma. We have so much arthritis that we deal with. Trauma is part of it. And each one of them that is more trauma is now interested in arthritis, and there's a lot of opportunity for people who are interested in developing hand and wrist products, for instance.
Right.
And I think shoulder too, hearing I think we're pulling back from everybody gets a reverse because it's easier to do, that there are more anatomic solutions throughout the musculoskeletal system that need to be had by orthopedic surgeons like us.
Absolutely. Well, that's a fascinating conversation. Thank you so much for giving us a glimpse into your journey in research, in product design, and innovation, as you say, in all forms, not just implants, but the whole spectrum of what it means to think creatively as an orthopedic surgeon.
You're so welcome. I think everyone has that creative drive, and it's just a question of nurturing it and kind of jumping in.
Perfect. Well, thanks again. We have Dr. Amy Ladd from Stanford here with us, and I appreciate your time to listen to us today.
Thank you.
Thank you for listening to this episode of the AAOS Now podcast. Production and editing by MK Quinn Media. Don't miss out on future episodes of the AAOS Now podcast. Bookmark our page, aaos.org/AAOS-now-podcast. Or subscribe to the Bone Beat podcast channel on Apple Podcasts, listen on the Health Podcast Network or Spotify, and watch select episodes on YouTube.